and where ANU is located. So this is where we'll be broadcasting to you from, and I would like to pay my respects to their elders, past, present, and emerging. So my name is Evangeline. I am one of the student volunteers for our program. You may be aware that our program is called The Link. And joining me are my colleagues. We've got Dipti Talalika, who is an associate professor in hematology, and she is also the program lead for The Link. And I'm also supported by Neha Gupta, who is another medical student volunteer here at the ANU. If any of you who are interested in being part of our team, please feel free to reach out to us and I'll send you an email in the following slides. So before I introduce you to our speaker for today, there's just a couple of housekeeping notes. So you will notice that all of the attendees have their video switched off and microphones on mute. This is to prevent and reduce any interference during our session tonight. But in saying that, we do encourage each and every one of you to please interact with us. So if there are any questions or any ideas you want to share, please feel free to use the chat function of Zoom. And there's also an option for you to post your questions anonymously as well. What we might do for tonight is we'll address all of the questions at the end, but feel free to roll those questions throughout the session. And towards the end of our session, there will also be a poll that we will launch, and I would encourage you to vote, and that will provide us some feedback so we can continue to monitor our progress as a program. And if you have any technical issues or questions after the talk, please feel free to email us at this email address here, and one of us will get back to you. So that's all I have in terms of housekeeping. So on to today's highlights. So I'm sure, like myself, a lot of you are looking forward to tonight's webinar. So we have Dr. Ian Marr today, who is an infectious diseases physician and also a microbiologist. We are very fortunate here in Canberra Hospital because he is part of the infectious diseases team here, and he brings with him a wealth of experience and knowledge. So he has worked extensively in providing medical care as well as education to low and middle income countries such as East Timor. And he has been a very important part of the UK sponsored antimicrobial resistance project, which is called the Fleming Fund in Timor-Leste. And together he has worked with his colleagues at the Menzies School Health Research. So I'm sure that tonight will be a very engaging and educational talk. So without further ado, I'll hand over to you, Dr. Marr.
Thanks very much for that kind introduction, Evangeline. Yeah, so it's a real pleasure to be able to talk to a crew, I guess, of like-minded people here tonight. I do encourage questions. I really want to, I guess, make this interactive and me to be able to answer those questions if I can. And so at any time, if you have any questions about any of this content, please slip them into the Q&A. So we can get to them, and we will make time. I'll make time for answering those one by one at the end. I think that's probably one of the more valuable things in this. So I'll just try and share my talk so you can see my slides. Not sure if that's coming up at the moment or not.
I think you've shared the Zoom screen, Dr. Marr.
Sorry about that, guys.
This meeting is being recorded.
So thanks for the pause there. This slide, I guess, pictures the topic which I'll be talking about tonight for the next 45 minutes or so. And this is really about a passion of mine, which is attempting to improve the diagnostic success in low middle income countries. I have a passion because of work that I've done in East and West Africa that has sort of engendered in me an understanding of the lack of diagnostics in developing countries, and gave for me an understanding of the need in global health for better improved diagnostics. As Evangeline said, I'm an infectious disease physician and lucky enough to work with a great crew at Canberra Hospital currently, and I'm also trained as a microbiologist, and so the diagnostics is really down my alley. The first thing to say is that there is no financial conflict of interest in relation to any of this. None of the equipment that I'll be talking about or any of the companies that we relate a lot of our work with related to me, and I get no financial benefit out of any of this. So the first part to talk about really are what are the impediments with making a good, clear, rapid diagnosis. And depending, I guess, where you are in terms of your medical journey, it may be pretty clear to you, or it may not be very clear to you. But some diagnoses are made clinically, some are made with laboratory assistance, and some are made with radiological assistance as well. It comes down to history, it comes down to a physiological exam, but it also comes down more and more to very beneficial diagnostics. And some of the impediments that I'll go through in the next little while really talk to how, I guess, relevant these diagnostics are to help us in our decision making. As an infectious disease physician, we end up with pretty broad differential diagnoses at the end of our history and our exam. And a lot of the art and the craft and what we're doing is trying to rationalize the tests that we may do to try and finally get to the end diagnosis so you can give the correct treatment. Now, without testing, without laboratory support, it makes it very challenging in those situations to be able to get the correct diagnosis. And so the impediments that we struggle with, a lot of those in LMIC countries are actually impediments of laboratories and not having reliable diagnostics. An example of this is, as was sort of outlined earlier, in one particular country where I've had the most work recently, and this is in a country called Timor-Leste. This is a small country not very far off the northern border of Australia. It's a country of 1.29 million people, and it had its independence restored in 2002 after a fairly bloody occupation after Indonesia exited from its country. About 50% of the population are estimated to be under the age of 18. And so it's a very young country, both, I guess, democratically, but also in terms of the population. But unfortunately, a lot of that population are fairly unwell in terms of health outcomes. It's the most stunted country in terms of Southeast Asia, and the TB incidence there of 498 per 100,000 is one of the highest in the world, not the highest, but one of the highest in the world, with only really 54 to 60% of those people actually getting adequately discovered and treated. Zooming in on the country, you can see a line down the middle down here, and this particular line separates East and West Timor, with this portion over here on the the west is Indonesian, and then the portion over here is East Timor on the right-hand side. Timor also has an enclave called Akusi, which is a small port that was originally hived off many centuries ago, and that Akusi is actually at their landmass as well. The entire country from north to south is just over 100 kilometres, and then from the east to the west, you're talking about in the order of about 300 kilometres. So it's not a very large island nation, but it does have 1.3 million people. In between here is some very high mountainous ranges, and you'll see in some pictures later, which make traversing the country and access of healthcare quite challenging. In terms of the backstory, it gets a bit of its money from tourism, but the vast majority of the income that comes into Timor-Leste is actually from offshore gas and oil, and only a small portion of their tourism or gross national product is from tourism. There's lots of communal living, as you would expect in LMIC countries, with these, I guess, huts in Dili centre. So this is the main city, scattered around, and people live in communal sort of areas, and there may be 2 or 3 families in this sort of area living together. Have some pretty poor infrastructure, and as we unfortunately learned in sort of trying to set up this project, the second slowest internet in the world, and this makes it even more challenging to attempt to do what you're hoping to do. And a lot of our work in Timor-Leste was actually centred around Dili. So Dili is the national capital, situated on the north coast. It has a population of approximately 300 to 350,000, and then 1 million of the other population live in the districts. And this is the National Hospital here. It's just a screenshot of that. And this is called HNGV. It's a 295-bed hospital that is in Dili, the referral hospital. And this is what it looks like when you start to go up into the mountainous areas. You can see the coastline down there, and you can see that it's quite mountainous, and it's actually fairly rural, and there's not a lot of infrastructure in these areas. There are labs scattered throughout the country and many of the other smaller towns, and this is, I guess, the sort of standard laboratories that you'll come across traversing through the country. And so you can understand that healthcare in a place like this with poor infrastructure, poor roads, and laboratories that is, I guess, what we would expect in Australia, and maybe other parts of the world, makes things challenging. National hospital, so the HNGV has a national reference lab next door to it. And in 2018-19, when we first started going into the national lab to try and get diagnoses, this is what we saw and what we came across. So there were freezers with doors that were frozen open. There is basically plates that are sitting on open benches, and using manual methods of identification, these things called APIs, to try and identify organisms. There was power that would go on and off quite a bit, which would make doing any diagnostics challenging. There was intermittent water and electricity, obviously, that seized up the machines with brownouts and would often damage the air conditioners. There was plumbing issues as well, and there continues to be some to this day, but throughout the country there are major issues, I guess, with a lot of the infrastructure, and there was no sort of clear delineated purpose for waste management. And so these pictures, I guess, taken in the microbiology lab are reflected again in the hematology lab, in the biochemistry lab, in a lot of the different aspects of diagnostics that you generally come to rely upon, just weren't there. And so as I'm an infectious disease physician and a microbiologist, a lot of this talk will focus on bacteriology and the efforts that we've gone to try and improve that. But similarly, there are struggles, not just Timor-Leste, obviously, but many other countries with other elements of laboratory science, and that includes the biochemistry, hematology, toxicology, and anatomical pathology. So this is sort of histopathology and radiology as well. And whilst I won't talk to each one of these, the lessons, I guess, that come out from our work in bacteriology can easily be extrapolated to those other areas. And in building systems for microbiology, we've actually assisted in many other areas in laboratory support and diagnostic support for the country so far. This is a little aside, which just paints the picture, I think, quite well, and gives context. Especially, I think, if you've done most of your medicine in a sort of a developed country where there's been high incomes, where there's been good access to healthcare and diagnostics, we can have a bit of a skewed idea about what causes death and what causes illness. So this is from the Lancet, and you are able to go to this. It's free access, and you can do it yourself. And really, it's just a graph to be able to show you what is the world. You can pick your location And so this instance, I picked Australia and chosen deaths and the cause of deaths, and the proportion and the colour gives you an idea about what is actually causing the vast majority of deaths here in Australia. So you can see ischemic heart disease, stroke, lung cancer, colorectal cancer, Alzheimer's, COPD make up a large chunk of that. Over here on the right-hand side, you can see the red box, and this is actually infections that are causing death. And so there's little boxes in here. If you hover over those, you can actually understand what they're saying, but they're so small at the moment you can't read them. If you do that again, however, you take a low socio-demographic countries, so LMIC based countries, and that's really all you flip. You can understand now why diagnostics, in especially my specialty, is such an important imperative. And so this red box of infection blows out. And so that means that people that turn up with infection are much more likely to die, and it's a larger cause of death in these locations. It also means that the diagnostics for this are actually much broader. So the differential is very broad for fever. People turning up with fever could have one of a number of things in these tropical locations, and making it much more challenging. It's not like, I guess, high-income countries where sometimes you can guess with your antibiotics and land on the right diagnosis, but the differentials are much broader in these places. And because of that, and because of, I guess, some work that we'd done early on in and around the 2018-19 period, we had some benefit of trialing some laboratory equipment that we put together. And so this is one of our first forays into attempting to improve the diagnostics there in Timor-Leste. And it is a mobile laboratory that we helped design for what's called the National Critical Care and Trauma Response Centre. And so this mobile laboratory has at its centerpiece manual blood culture system. And so this particular blood culture bottle system is you take the blood, you put it in here with the culture media, and you can put this on the top. When this cassette on the top fills up with pressure, basically the fluid escapes in here because of the CO2 that's building up because of bacterial turnover. And so then that tells you that the bottle is positive. And so this manual system on the back of what we call a multiplex PCR machine, the biofire film array, was able to identify those organisms as soon as they went positive within 1 or 2 hours, and those results to be relayed to the physicians that were treating them. And we had some pretty good success with this, taking it over. We found 117 different pathogens over the period of time, and a number of those in blood culture, some CSF pathogens, as well as a lot of GI pathogens that were there, that were all then sort of subsequently referred through. One of the next things to do, though, and whilst we were there, we started to really, I guess, discover the gaps, and it was commented on by a lot of the doctors there that people aren't getting better. We're giving them treatment, but they seem to die anyway, and we're not quite sure what's going on and why that's the case. We did some investigation, and this is a paper publishing that, showing that the rate of resistance in Timor-Leste was actually quite significant. You can see on the lower row here, the amount of what we call MRSAs, fairly low compared to its EBL phenotype, or the bacteria that would be resistant to ceftriaxone, a standard antibiotic of choice, was quite high. And this certainly married up quite well with what we were hearing from the physicians that were treating patients, that patients would die regardless of the antibiotic that they were getting. In most instances was ceftriaxone. And so this really flagged for us a problem of growing resistance that was already there, that was going undiscovered because of a lack of, I guess, diagnostics. And so thinking about it hard and thinking about the challenges, we started to understand what is really necessary in these locations to be successful, and why these things haven't happened before. And now this, I guess, translates not just to Timor-Leste, but to many other countries in Southeast Asia, in the Pacific. And to get diagnostic success, you really need to tick off each one of these. And so the limitations to clinical microbiology could really be limitations to hematology, to any of the sort of result-based diagnostics, one of which here is infrastructure. So you need running water, you need power that's on all the time, and you need buildings that are able to withstand and meet sort of PC2 criteria. You need consumables that are continuously supplied. So a lot of these small island nations are reliant upon ships to dock and to bring supplies from overseas, because there's no local production of many of the reagents that you need. And that requires lots of logistics. It has long lead times, and you may have short dated stock, much like if you were running a restaurant. And you had to buy all of your stock 6 months out. It'd be very challenging, especially if they turned up late or they turned up expired. So the absence of local production really means that you need to negotiate with often multinational suppliers of those reagents, and many of those multinationals aren't that interested in the small amount of supply that you'll be ordering from them, because they're just such large companies. Oftentimes, if you can't get your products through those large multinationals, or they're too expensive or the delivery price is too big, you go to whoever can deliver them. And in many instances, the people that you go to will get you a nice price, but oftentimes the products that turn up aren't real or they're fake. And so because there's no, I guess what we call ISO standards and quality assurance of the products that arrive, then it's very tricky to be able to prove that the stuff that you've bought is actually legitimate. And oftentimes we've actually encountered countries buying products that are fake, and it's already too late. The money is largely paid before that's discovered. In any laboratory, it's very important to get what we call reference materials, so you know what you're dealing with, whether it's any of the specialties, hematology, microbiology, and those reference materials are actually, especially in microbiology, quite expensive and hard to get. So they're called ATCC organisms, and you need to keep them at a certain temperature at minus 80 degrees in deep freeze, so you can grow them out, and so you can basically use them as what we call QC or quality control organisms, and they can be hard to transfer. Along with this, there's a widening identification gap, especially in our specialty of microbiology, of what they've been using traditionally as these biochemical tests called APIs, versus what's now rolled out in the form of mass spectrometry. So mass spectrometry, I'll talk to a little bit later, is done by large machines that are able to use fine-tuned lasers to be able to identify organisms rapidly. And so this has really changed diagnostics in Australia, but it just hasn't really dispersed out into small island nations in the Asia-Pacific region. Coupled with all of that is some challenging, complicated rules for susceptibility testing that work well in high resource places, but not necessarily in LMIC countries. One of the other big factors that we noticed when we were there is that a lot of the results that were being produced on pieces of paper, and those pieces of paper may or may not make it back to the clinician that ordered them, especially given that a lot of those pieces of paper were hand delivered by people because there was no postal service. And so we noticed that a lack of what we call lab information systems, or LIS systems, or LIMS as they're sometimes referred to, in electronic based freeware systems, meant that results didn't actually get back into the hands of people that needed them. Now, negotiating with different LIMS companies around the world, we soon quickly realised that these are for-profit organisations that want to charge quite a bit for their software, and weren't willing to give up much of it for free. And so we had to think about this strategically and how we can get results into the hands of doctors easily. We noticed when we were there that there's pretty poor communication between lab and clinicians, and I think it's really just based on the fact that if you have start and stop diagnostics because your ships never come in and the laboratories aren't able to keep up with sourcing the reagents, then clinicians, I guess, lose interest in doing the test because, well, there was no testing available last month. Why would I bother this month? It's probably not there. And they also, with the poor quality reagents, lose, I guess, interest in actually testing because a lot of the results that come out of it are questionable as well. We noticed there's no professional standards and very few pathologists, so doctors that run laboratories and/or microbiologists, and there were limited training opportunities for scientists. I guess all of this really just bent down to one of the biggest issues in all of this, and that's that there's insufficient funding, and that meant that a lot of this couldn't be fulfilled. So the reagents couldn't be purchased and equipment couldn't be maintained and infrastructure couldn't be built because there were insufficient funding. And insufficient funding came back to, I guess, allocation by ministries, not just in Timor-Leste, but I've seen this now globally, that underappreciation of laboratory diagnostics certainly is all around the world. Probably less so now that COVID's happened, that everyone now understands that labs are very, very useful things. But certainly 2019 when this started, that was not the case. And so how really now, after hearing all of that and being, I guess, so pulled down and thinking about how big the problem is, how do you fix each of these elements, was one of the thoughts that really popped into our brain, and sort of tried to dream up what actually could we do to try and arrest this situation and just turn it around. And so looking at each one of them, I guess you can't think you can do it all at once, but breaking away and chiseling away at one at a time was certainly what we were attempting to do, and to think about how we can progress things. Luckily for us, other people around the world were having the same thoughts at the same time. Antimicrobial resistance being, I guess, at the center of many of those thoughts is, I guess, the next pandemic. It's the next pandemic that everyone does believe is coming, and really, in many ways, is already here in many of these countries. And antimicrobial resistance really needs to be measured to be able to be shown, and without laboratories, it's very hard to measure. And so this group, it's UK funded, the Fleming Fund had money that was put together from UK aid, about 275 million pounds, that was put together to go towards setting up laboratory infrastructure. And Timor-Leste was actually, luckily, one of the countries that was flagged on that early on. And so we were lucky enough to partner with the Fleming Fund and to progress all of those buttons that you saw earlier in the right direction. One of the first things that we did, working through the Menzies School of Health Research, who now has a large presence in Dili and Timor-Leste, was to bring a team together. Notably, doing all of this work, building infrastructure and just turning up, building and walking away was never going to work. And so I think one of the things, and probably the outstanding success of where we've gone so far, is the fact that we've been able to mentor people side by side and build all of these people up so they can run the laboratory systems, the diagnostic systems themselves independently. And that's one of our, I guess, greatest successes, I think. And so knocking off the first button, so infrastructure, we had money, and we designed enough of the laboratory to be able to renovate some of it and extend some of it, and to build a place for waste disposal, as well as make it PC2 standard. We were able to put in ventilation systems so there's adequate airflow, and make sure that there was enough storage, as well as air conditioning all the way through. This also came with it some water pumps to secure the water, as well as an air filtration system in what we ended up building into it, a COVID laboratory. We're also able to put in incinerators, portable incinerators, and a waste section at the back to adequately dispose of all the waste. In terms of the second button, the consumables and logistics, this is obviously a major problem, and this continues to be a major issue around the world, really. Supply chain is really come to the fore, and I think we know this more than ever now, living in a place like Australia, but many island nations, I'm sure, will be well and truly aware of this, is often reliant on ships. And when ships don't come into port, or they sail past, is what happens in Timor-Leste. At times, that means that reagents aren't delivered. And so Menzies School of Health, with some of the funding from Fleming Fund, were able to secure supply lines. We're able to patch together a continuous supply of reagents from some of the large multinational suppliers of reagents, and also to enable us to buy in bulk and have a better inventory supply to make sure that what we were supplying was continuous and not start and stop. And this really comes down to a lot of effort from a lot of individuals to be able to do this and to make sure that there's continuous supply. I think we're very, I guess, lucky and blessed in an Australia setting to be able to have continuous supply, but it's not the case in all countries around the world. We have manufacture of products within our shores, but we also have fairly secure supply lines from planes and shipping. But this isn't the case in Timor-Leste, where they do not manufacture into the laboratories reagents at all. And so there needs to be access and deals made with multinational suppliers. Often, and as we found in the midst of COVID, flight schedules are stopped, blocked, ships don't come and don't arrive. And so you end up trying to do laboratory work without a continuous supply of reagents. Some of the larger issues as well that we faced was that there needs to be a cold chain for requirements of many of the lab reagents, so they don't expire, and there needs to be specialised import permits for a lot of the dangerous goods. Also, turning up as issues and ended up being a lot of the stock that we were receiving was short-dated stock, and because we weren't, I guess, the large laboratories and with the large buying power, there wasn't much care given, and so negotiating with these large companies on a small budget is certainly very challenging, and that's what we've faced. But this isn't just, I guess, to talk about Timor-Leste in that sense, but many other global nations have these same supply challenges now and continuous issues with supply. One of the things that I did mention earlier is the quality assurance, and so this is just one example of that. So these are blood culture bottles. So these are automated blood culture bottles that are supposed to fit into what's called the Bacti Alert system, a bioMérieux product that fits into blood culture incubators. These particular bottles look the right thing. They actually have the same sort of barcodes on them and they scan into your machines, but the closer you look at these, the closer you realize that actually they are fake, and the organisms that should grow in these don't grow in these. And so we discovered that there'd been large numbers of these bottles that had been ordered and used and would never go positive. And since then, we've discovered actually that a number of other Pacific Island nations had also bought the same stock, thinking that they were ordering legitimate products, but they were not. And so we were able to, I guess, identify these issues and go back to suppliers and say, actually, this is incorrect. You've been giving us erroneous stock. We need to change that and make sure that we went to better suppliers. The reference materials, as I said, had to be stored at -80, and so we secured pathways for that with -80 freezers that were continuously supplied with electricity and generators to back them up. Some of the, I guess, the biggest gains that we've had in terms of identifying the organisms that are causing infections in people come from this particular machine. So this is called a mass spectrometer here in the center. And so these organisms that we grow out of people's blood cultures or out of urine, they are grown on plates. And traditionally they're run through these things called APIs. And so these are little biochemical reactions that tell you after 24 or 48 hours of incubation what these bugs or bacteria are, and they can then give them identification. And so it may be it may be E. coli, or it might be a bug called Burkholderia or a Pseudomonas or something else. And so you're able to then put a label on it, and then you're able to give susceptibility advice on what the best antibiotics are to treat that for the patient. Now, you can see if that takes maybe 24 hours to grow there and the API takes another 24 to 48 hours, that you're already 3 days behind with your identification of the organism. And so this mass spectrometer here in the middle, called the Bruker mass spectrometer, is about $300,000 US, was what we were able to install with money from the Fleming Fund. And this is a particularly good piece of technology in that the mass spectrometer has a laser that hits it in this negative pressure tube and fragments the organism's ribosomes up, and they are then able to give you a protein spectral structure, and within about 10 to 15 seconds give you the organism ID immediately. Now, these are mass spectrometers are what's used in laboratories all around Australia now, but there had been no mass spectrometer placed into a Southeast Asian laboratory prior to this, and so we were lucky enough to be able to place the first one in Timor-Leste and to turn things around rapidly in terms of organism ID. The second large piece of equipment here is what's called a Phoenix, and these are automated susceptibility machines. And these machines take the organism off a plate here, and you can put them into a cartridge, and it can tell you what the susceptibility profile is for those particular organisms. And this was another one that we're able to luckily install and to really speed up the process of organism identification and susceptibility, so you can get the right antibiotics into people. This is just another picture of the inside of the mass spectrometer that we installed and had serviced. This is a day of service. We were opening it up, and these particular plates here just zoomed in on where you basically colour in the organism here with a very, very thin film of the organism on a disc here, and you put something called a matrix over the top. And so this matrix then allows the laser to hit it. And like I said, the time of flight tube here, the negative and positive ions hit the top here and can give you a spectral readout and tell you what the organism is. So a great piece of equipment, but this particular piece of equipment is very, very testy and doesn't like dust, doesn't like being tilted any more than 3 degrees at any one point in time. And so you have to be very careful with the installation and running of this. Certainly doesn't like brownouts, and certainly doesn't like the electricity that comes out of the mains in a country like Timor-Leste. And so we had to make sure that it was secured electronically and through the power systems of sine wave power and a lot of different things that I didn't think I would have to learn, but I ended up having to learn how to do. And so this just really talks about the mass spectrometer and some of the issues in terms of this. And so some of the problems are obviously dust, as I've alluded to, but also the maintenance of this machine. In the midst of COVID, the country shut down and for about 12 months didn't let people really in or out. And so getting in and doing maintenance on this equipment was very challenging, and we had to learn how to do that at a distance. This is just another picture of the inset of the Phoenix, this machine where you can do susceptibility testing rapidly on organisms and get your answer, usually within 8 to sort of 10 hours if it's what we call a gram negative, or maybe a little bit longer for gram positive. But this machine itself also is fairly sensitive in terms of it doesn't like dust, doesn't like temperature variation, and certainly doesn't like the brownouts again. So we had to secure that item pretty well. Some other things that we did was install automated blood culture machines, and we have a number of these now scattered throughout the country. This is just one picture of one. And so if you take blood culture, you stick them into these machines, and the bottom of these Bactec bottles, they actually change color as the organisms grow on them. And so then the machine can detect it and alarm for you, so you can tell that there's a positive blood culture. And so we're able to install these in a number of, like I said, locations and start a blood culture service all across the country. We also went through and did teaching and sort of brought everyone, I guess, up to speed in terms of what we should do in terms of guidelines, and making sure that we're able to follow what we call the UCAS guidelines on how to do susceptibility testing, and made sure everyone was aware of the process and the procedures that we were required to do. Just talking about guidelines, a lot of them lean heavily upon the different types of media, and if you don't have the right media, then it's quite hard to do the right susceptibility testing. Now, the right types of media in Timor-Leste usually require either sheep blood or horse blood, and sheep not very easy to find in a country in Southeast Asia. There's just not many sheep, and so what had actually happened is that scientists would donate their blood so they could then put them into agar plates, and so you could grow the organisms. And so on days when we didn't have enough blood, basically the scientists would turn up, or they'd send me along, and we would donate blood so we could actually make some agar. We were lucky enough, though, with some of the money that we were provided with, to actually then purchase horses. And so we found out that whilst there were no sheep, there were horses in Timor-Leste, and quite a few of them were able to incorporate this into the blood agar pathway, and to then start making horse blood agar, which is now a very successful program. Excuse me. So one of the, I guess, other elements to all of this, so I alluded to this to the button 7, is getting the results into the hands of doctors and making sure that the results are there for people to access quickly. And this was the IT system when we turned up, and this is the IT system after we fixed it. There is now also what we call a LIMS system. And so this is a screenshot on the phone of doctors when they sign into this particular system, and they're able to access all patients' results, which I think there's about 250,000 results in them now that they can access historically and track over time. And so this is a system that's linked up, an automated system that's linked up from hematology analyzers, biochemistry machines. So every result basically going through all the labs in the country are now punched into this system and all backed up in real time. This also allows us to come in to also assess the machines and make sure that they're actually being tuned and QC'd correctly, and they have what's called the Levi-Jennings chart done correctly as well. And so this sped up the process and allowed paper to be disposed of in the laboratory, and also for notes to be sort of tracked historically over time, and for data extracts and antibiograms to be performed as well. One of the other key aspects, as I alluded to earlier, is the poor communication between the labs and the clinicians. And this wasn't just between doctors, but it was, I guess, a misunderstanding because of what was the lab doing. We were, some distance away from the hospital, and so we spent a lot of time engaging doctors and nurses and cleaners, as well as some of the doctors in, showing how blood culture systems work and bringing them into the lab and experimenting with, hand plates and showing them organisms that they'd grown off themselves on their own swabs. So people understood the process of what microbiology was and how it actually applied to their patients as well. And so then the last couple of buttons we have now spent, I guess, the last 18 months doing fairly heavily. And so these are upskilling the professional development and making sure that there's training going on. Whilst there's still no professional standards in the country, we do continue on with fortnightly journal clubs. We have a course now for course material of the scientists to continually teach them. There are weekly teaching sessions and exams with this, and we do daily rounds through Zoom, updating them with the results, and if they have any questions they can ask. So I might just pause there just for a second, just to encourage you to enter in any questions that you have into the chat before I move on to the last sort of 10 or 15 minutes. And yeah, please feel free to ask any questions. Don't think that any one questions outside the realm. Please feel free. Any technical questions, any larger sort of systems questions as well. So the last part, really, what are the emergency issues and how do we adapt to these? I've really put this in just to sort of signal after you do all of that work, you have some other items that you have to address. And one of these items is this. So this is an antibiogram. And an antibiogram really just goes through all of the organisms. So you can read these on the left, and then you can read across the top here the organism's susceptibility. And so these organisms on the left, we've got them as gram-positive organisms and gram-negative organisms, and some of those names you may have heard of. Some of these organisms are very, very common. So there's E. coli here, and you can see we've had 174 in this particular antibiogram that was done. And if you look across here, the best antibiotic for those. And so meropenem is the best antibiotic. But if you ask for meropenem, there's only a very small supply in the country. And this is a broad spectrum antibiotic, and we try not to use this all the time. But we don't have tazocin, and the resistance to ceftriaxone is actually quite high. And so 37% resistance to ceftriaxone means that oftentimes you need meropenem or you need tazocin to be able to cure these infections. And this is really striking. So this was not known before we went in, and now it is. And so there has to be an increased supply of meropenem, and then concern about increasing resistance even to meropenem now. And this is one of those organisms. So with the increasing amount of meropenem that's used, we then see that these organisms start to poke their heads through. So this is called an Acinetobacter baumannii, otherwise known as an MRAB. And MRAB stands for multi-drug resistant Acinetobacter baumannii. And this came out of a patient in 2020. It's the first time we'd found it. This was resistant to all tested antibiotics. There was nothing that you could actually treat it with. Of course, this wouldn't be a talk about laboratories unless you could talk about COVID-19. Excuse me. And unfortunately, COVID-19 has really affected the world around us quite significantly. We had to convert a lot of our diagnostic time and effort into diagnosing COVID-19 for the country. Now, fortunately, Timor-Leste has done very well with its vaccines, and it's gone through 3 waves, but we did convert a lot of the laboratory space into this, and luckily enough, we've done about 200,000 different tests now for COVID, and the waves have passed. Lastly, and this is just really just to talk about the infrastructure issues that continue to plague low and middle income countries. There was a cyclone in April of 2021. Whilst we thought we'd done all this good work and we'd made some really good progress, unfortunately, this happened. And you can see here quite a bit of rain, and you can see this is laboratory in the middle of this. The laboratory unfortunately got completely flooded, and this is some real life pictures of inside the laboratory. the same day that the flood came through, bringing a lot of dirt and mud all the way through the laboratory, taking obviously all the power out and ruining all the water. And this was the entire city of Dili that you can see here from the air. And you can see that a lot of people would have been flooded out, and a lot of illness and sickness would have been carried through with this. And so this just speaks to the fact that as well as you can do things, things like natural disasters can come, it can take, excuse me, much longer to fix. Luckily enough, though, because of the strength of the people there, they were able to fix this quite quickly. And you can see here a clean lab. This was only 3 days later. All right. Sorry about that. I'm losing my voice there at the end, but I'd just like to, I guess, thank a few people. Obviously, UK Aid, the Fleming Fund, as well as the Indo-Pacific for a lot of all the Centre for Health Security for a lot of their funding, as well as Menzies. Thank you.
Dr. Marr, thank you so much for such an insightful talk and for sharing your experiences. Very eye-opening and very inspiring. So thank you so much. We have a lot of very excellent questions that have come up. And while I go through them, you'll also notice a poll that will be launched on your screen. If you could please just rate the talk and provide us with feedback, we would really value it. So Dr. Marr, would you like me to read those questions or would you like to read them?
No, that'd be good if you could, actually. Thank you.
Of course. So I'll just launch them. So we've got some incredible questions here. I'll just pull them up. So I think the first question here is quite relevant to us. What does Australia do to support diagnostics and medical care in general in neighbouring countries?
Yeah, it's a really good question. So the funders on that last slide, the Centre for Health Securities, they're putting a lot more money into this. And it's certainly been, I think, raised now that COVID's gone through. It wasn't such a major issue beforehand, but yeah, Australia is now putting a lot more money, especially into the Pacific Islands, for diagnostics in its local region, realizing that laboratories do have a lot of power to be able to, help with the health, but also help with the networking of health systems as well. So there is major money coming through from the Centre for Health Securities that is really backing a lot of laboratory work, which previously probably hasn't been there. And I think we can thank COVID for that.
Thank you. What can be done to compel profit-making companies to have greater corporate social responsibility? Quite a big question there.
Yeah, it's huge. I don't know the answer to it. Part of the problem, I guess, with laboratories is that there's large multinationals that really command the largest amount of market share. And a lot of the small players really just get absorbed up into them. And for instance, so there's only 2 automated blood culture systems in the world. There's not anything else. And so if you want one, then you have to either go to one of those 2 companies. How do we make them more responsible? I think, the Fleming Fund is part of that. And so them engaging in these locations and, having equipment there means that they now have to start thinking about maintenance. They now have to start thinking about supply lines for those locations because they've sold equipment in there. But yeah, it is really challenging. It's all about profit and market share for those particular companies. And so making it so they have a social responsibility can be challenging, but I think it needs to go through to their boards. They need to think about it not just as a profit-making venture and sustainable sort of profit-making schema, because they're not going to make as much profit simply, and they need to think about other things that they can do to assist. But yeah, it's quite large, it's quite massive, and I think Fleming Fund has really cracked that open and shone a light on it, a very big light on it.
I guess on the same sort of wavelength, is there a role for the Fleming Fund to help educate communities around antimicrobial resistance, especially when buying medicines over the counter?
Yeah, it is. It's a big part, actually, of what they're doing. So there's a Fleming Fund 2 grant it's going into that. And I guess the first part that they would have been thinking of would have been that that they need to shine a light on what kind of resistance is out there, and it's quite clear that it's there. I think we knew that, and so what's the next part? So it's antibiotics in animals, it's antibiotics in sewage systems, it's making sure that, like you said, that you can't buy ciprofloxacin with your Coke on the corner store, which really throughout last 10, 15 years throughout Southeast Asia is still I think you can get ciprofloxacin anywhere. And so advocacy at that high level is certainly going on. It's going on now at the ministry in Timor-Leste, but also in many of the other 27 Fleming countries, to educate people about that. But it's hard. It's very challenging to do. And you have to have a regulatory legislative pathway as well. So antibiotics that are coming into the country, maybe they're being squirreled in, maybe they're not coming through the docks. Yeah, it's very hard.
I think something that a lot of our audience members, myself included, would really like to know, as well as future healthcare workers, especially those that are interested in working and volunteering in LMICs. Can you advise us on how, I guess, we can start the process and what we can do to engage?
Yeah, I think I was in a similar position, probably. At that time of medical school and early medical years. And I think one of the more important things is just to really stay interested. There'll be times when you can do it and times when you can't. And just because you can't do it imminently and go in and, do large projects doesn't mean that you shouldn't try and be engaged and interested in that and try and find what you can and get involved in areas that you can. There are more and more, I think, opportunities in the Asia Pacific region that you can get involved in, and it may be sort of short-term work where you can go in and assist or understand a little bit about what's going on. I think the link is a really good way of making networks and making links with people in these locations and understanding what's going on. So I'd encourage that.
Well, we're very lucky to have you here supporting us as well. We do have some more practical questions, such as how much does a mass spec actually cost?
So if you're thinking of getting one, so it's about 300 to 350,000 US dollars. So you might want to go for a Ferrari or something. It's probably easier to use. These machines are finicky. They break down. They're great when they work, but it's they're an expensive piece of tech. And I must say, there's been a lot of consternation about whether it's the right thing to do. I think it is. We were the first Fleming site to actually install it, and I think it's working well for us.
There's a question here about ceftriaxone and why resistance to ceftriaxone is so high. Is it just because it's been historically used a lot?
That's a really good question, whoever's asked that. It's a sort of a complex answer. I'll put my microbiology hat on for a second, but the genes that actually confer ceftriaxone resistance are called extended spectrum beta-lactamase genes, and they produce this enzyme. And there's many of them, but actually the gram-negative organisms like to swap those genes very swiftly and quickly. And they're usually swapped between organisms that live in your gut, and those organisms that live in your gut are obviously fecal organisms, and so they're E. coli and Klebsiella. Now, the thinking was that a lot of the antibiotics used in animal husbandry was driving a lot of that resistance. But there's probably been just as much sort of thought now about the septic and sewage practices of fecal flora and how they can spread resistance genes in an environment. And this is certainly what we've seen in Dili, where there's close living people, and you see this, I think, in the subcontinent as well, that there's continuous spread from the septics that then go into the bore water, which then is drunk, which is then circulated around, and the genes are able to swap around and basically spread quite easily in those particular locations. And so you end up with higher rates of resistance, because you're using these particular types of antibiotics and these genes hop around quite quickly. but then because that there is inadequate infection control practices in these locations. And that makes it actually pretty overwhelming because you think of that high sort of view drone picture of the flood, right? And if you think that in Dili, they're actually, in that particular city, there isn't a septic sewage system. So they have septic tanks, and those septic tanks would be for individuals, toilets and systems, but there's no one particular system, and it drains into a network of sort of open dug drains that then tip out into the sea. And so that basically just means that infection control is a major issue. A town of 300,000, how do you now say, okay, you want to put in septic and sewage systems for that entire town? You're talking at a lot of money and a lot of cost. The scientists we work with, they get paid $2 an hour. And now you're looking at actually what the issues are. Huge amounts of expense if you want to try and stop that and want to try and arrest it. Yeah. So a long answer to say that the ceftriaxone resistance is easy to flick around between genes, and the antibiotic pressure means that these genes push around, but then the organisms jump around themselves.
Thank you. So in regards to there being limited resources, there is also a question about, would you possibly consider resorting to using expired products?
We setting up a laboratory, I guess you have to be very cautious about doing that. The stock that we have and we receive from the large multinationals, they always have a cushion period on them, so they don't want their stock failing QC whilst they're in the expiry date, within the date of use. And so when we get down to the dire period, when the ships hasn't arrived, when the planes haven't arrived, it is necessary to do that, unfortunately. But we do test them quite well with QC, and we make sure that the QC is up to date and that we're not putting out erroneous results. So we're sort of double, triple checking those sorts of things. But yeah, it does get down to it. And I know laboratories, unfortunately, all around the world have to do that, because it's either you have nothing and you put out sort of, we can't do the test because we have nothing, or you attempt to use those products very, very cautiously stepping forward.
Thank you. And there's a question about TB. So did you try any diagnostics for TB, experts, or the acid-fast bacilli smears, for example?
Yeah, so the Fleming Fund, we're very interested in bacterial resistance. Our next phase, actually, another DFAT funded grant that we have is for TB. And with COVID, we got quite a bit of money to assist, and we've scattered gene experts across the country to try and help with COVID testing. And so we're now going to leverage that and try and improve the diagnostics for TB. So yeah, we'll be going into that. They do AFBs, there's AFB smearing going on all throughout the country at the moment. But as you would know, that's probably only 60% sensitive. And these new Gene Expert Ultra cartridges are about 95% sensitive. So we think once we start this project, DFAT funded project, we'll see that there's probably a lot more TB than what we even think of now, and hopefully find it and treat it and cure it.
That's very interesting. We're looking forward to seeing what comes out of that. And in terms of working on large-scale projects, such as starting up a microdiagnostic lab, who do you seek out to liaise with?
I guess in answering to that question, the liaison in terms of all of those different button aspects is different. So infrastructure, so I had to liaise and try and find a building company that could build to PC2 standard. For the lab diagnostic equipment, go to the multinationals. For the scientists, try and find scientists. So it all depends on what you're actually trying to achieve and who you're liaising with. And then just keep, I guess, asking for help and asking for help and asking for help, which I've become very good at, because I certainly didn't even know how to lay a brick before I started this, but had to manage the build, had to do a whole bunch of other stuff that was sort of outside my wheelhouse. So yeah, getting used to try and asking for help and just going to people and trying to find and ask and ask and ask again is, I guess, now my skill set, because I know I certainly can't do this, by myself. You need help.
Evangeline, are there any questions on your end that you can see?
No, I think, yeah, all the questions are very, very good, guys. And I think we've answered all of them quite extensively. Yeah. I guess the one thing that some of us in the audience are interested in is low cost manual testing. So what are yeah, so I found it quite interesting, Dr. Marr, when you mentioned that you had to rely on the technicians and the scientists to donate blood in order to have AGAs. So can you talk more about low cost manual testing?
Yeah. On a sort of I guess a much broader pitch to that, or answer to that question, there's been, I guess, a lot of thinking about how you do diagnostics in these places. And so what we've set up, obviously, is a reference laboratory, a high yield reference laboratory, where the attempt is to have what we call a hub and spoke model. And so you have people that may come to their local clinic or the local health centre. They'll get their test and they won't be able to do it all there, but they'll send it into us and we can result them. Now, that works only if you have a logistics system, and only if you have vehicles that can travel back and forth, and making sure that you can get access to it and they can get results back to it. So that hub and spoke model is certainly what part of what we've set up, and we think that we will be successful with as we travel forward into the next sort of 5 to 10 years. The larger part and the larger question really is that the right thing to do? Is that actually going to be successful, or should we try and decentralize testing? And so I guess maybe that's what this person's alluding to, in that we have rapid tests for COVID now. You can do your own tests at home. We have smartphones. Can't we turn them into little PCR machines? And so there is a lot of work going on around the world. Gene experts, single door gene experts, you can put in your backpack, and you can travel around. You can put X-ray machines on your back and go up into the hills. And so there's a lot of thought about, is decentralized testing a better model? And if we can secure the sensitivity and specificity of those tests, that would actually give greater access to the regions and greater access to people. The issue with that is often supply lines and supply chain, and making sure that people are doing the tests correctly, even with the rats at home, right? How many people actually do them correctly and get the correct result? Now, if you try and multiply that over urine testing, blood culture testing, CSF, it becomes a pretty onerous thing. And so the first step, I think, is getting a good referral laboratory, getting a nice standard, knowing what's right, what's wrong, and then talking about the logistics behind decentralizing.
Great, thank you so much. I think we've answered all the questions. We've addressed all of the questions, and you answered them really, really well. Thank you so much for your time, Dr. Marr. I'm sure that our live audience, as well as those that will be watching the recording, will appreciate a lot from your insights.
Yeah, no problems, and thanks for having me. And I'm sorry about the coughing fits there at the end, but hopefully the answers all made sense.
No, they're great. They're really, really detailed answers. Thank you.
It was a very inspiring talk. Thank you so much.
No problems. Thank you.
And hand it over to Neha.
Yeah, so as part of our program's focus on healthcare in under-resourced areas, we are hoping to further explore this space, and the details for our next event will be available soon. So please keep an eye out on this space. And like we mentioned previously, if you have any questions, please email us. If you would like to join us, please reach out. We're looking forward to hearing from all of you, and take care and have a wonderful night. Thank you.
Great.